Welcome, and thank you for coming to the webinar series from the Ionia Foundation called Sight and Sound Bites. This bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. So today's topic is optic neuropathies. I know that this is something that that we've had a lot of interest in. As a matter of fact, as I said, we have a lot of people on the program today. So the full title, Optic Neuropathies, a Crucial Messenger and its Disorders. So I'm Lawton Snyder, CEO of the Ionia Foundation. The Ionia Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Ionia Foundation to support research are only made possible because of philanthropic support. So we always want to thank you for the support that you've provided as people who may be coming on to our webinar as donors, but we invite everybody to come to our webinar, but we certainly want you to know that support is welcomed and it'll help some of the work you're hearing about today. For our program today, chat will be disabled. We use just the Q&A question function, which is at the bottom of your screen. When you have questions, please type questions. You can do it anytime during the program. You can click in a question, click in and ask a question as you are thinking of it. But we'll save those questions to the end, and then I will ask our presenter those questions at the very end. We'll ask you to refrain from asking personal health questions that only you would be interested in hearing the answer to, but you can certainly send those questions to us, and we'll try to get an answer to you through email, and you can send it to Mr. Craig Smith, whose email is in your invitation. Please feel free to use the subtitle function for closed captioning down at the bottom of your screen, and then we will add you to our mailing list for future webinars. So again, presenting today's program is Dr. John Kocasarac. Dr. Kocasarac is a clinical assistant professor of ophthalmology at the University of Pittsburgh School of Medicine with our neuro-ophthalmology service. It's exciting to have Dr. Kocasarac today because Dr. Kocasarac is, very, very well prepared through his education to provide us with this discussion, because he did a residency in ophthalmology, but also did a residency in neurology and a fellowship in neuro-ophthalmology. So we're very lucky to have him on board here, and one of our newer faculty who's joined the department and helping us with our neuro-ophthalmology clinical services. So we're looking forward to hearing about these crucial messenger and its disorders related to optic neuropathy. So please, Dr. Kocasarac.
Hi, everybody. Thank you so much for the introduction. It's a privilege to be with you today. Today I'm going to talk about optic neuropathies. This is actually a very broad topic, so of course it is not possible to cover everything here, but I want to highlight some important aspects of the optic neuropathies, how we diagnose them, treat them, and I will talk about some recent improvements. So what is optic nerve? The optic nerve is a bundle of more than 1 million fibers and that carry the visual messages. So it is basically a messenger. You have one connecting the back of each eye to your brain. Optic nerve carries all the information, all the visual information initially, and then it continues with optic radiation. And that reaches to the back of our brain. That's actually where we see the visual information is processed in the back of our brain, which is called occipital cortex. It plays a crucial role in seeing, the optic nerve. When light hits the retina, which is a light-sensitive layer at the back of our eye, as shown here, special cells called photoreceptors in the retina turn the light into electrical signals. And these electrical signals come to the retinal ganglion cells, and around 1.2 million retinal ganglion cells constitute the optic nerve, which carries the information to the brain. And as I said, then the brain turns the signals into the images we see. And optic nerve gives clinicians a great opportunity It is the only nerve that we can see in an exam. We basically can see the optic nerve head, which helps us to diagnose many conditions. You can see it with a biomicroscopic exam, as shown in the left picture, with an indirect ophthalmoscopy. And I took a picture of a YouTube video. This guy was showing how to do your own retina exam by a smartphone. So it is possible that in the future, patients will take pictures of their retinas, and then it will be evaluated with artificial intelligence. And we will talk about optic neuropathies. Pathy means disease in Latin. So when we say neuropathies, it means diseases of the optic nerve. It is an umbrella term comprising all the conditions that cause optic nerve dysfunction. It may be related to blood flow disruption, which is categorized as vascular ischemic optic neuropathies. It could be related to genetic diseases, which is called hereditary optic neuropathies. Inflammation may cause optic neuropathy. We can see inflammation in demyelinating diseases, and multiple sclerosis is the most common demyelinating disease. Myelin is an insulating layer or sheet that forms around nerves, which enables nerve to transmit information more efficiently. Infectious diseases like syphilis, Lyme may cause optic neuropathies. Systemic inflammatory diseases such as systemic lupus erythematosus may be another cause of optic neuropathy. Tumors that compress the optic nerve may cause optic nerve dysfunction. Toxic causes, and the most common one is maybe methyl alcohol, especially in developing countries. When government put a lot of tax to the alcohol, people start to make their own alcohol, and these toxic optic neuropathies can be seen like an endemic disease. Vitamin deficiencies, especially vitamin B12 deficiency, is a well-known cause of optic neuropathy. Trauma may be another cause of optic nerve dysfunction. But in general, the most common cause of optic nerve dysfunction is glaucoma. There are more than 3 million glaucoma patients in the United States. But today, I want to spend more time on hereditary optic nerve diseases, because these are the optic nerve diseases that we don't have efficient treatment options, and many studies are being conducted for these disorders. In the others, for example, if there is an infectious optic neuropathy, such as syphilis-related optic neuropathy, we are able to treat it with a basic treatment option, like we give penicillin, and then we can treat this condition very well. Or if there is a tumor compressing the optic nerve, then we will remove the tumor, and this is how we treat this condition. For glaucoma, there are many medical and surgical treatment options with the main goal of preventing irreversible nerve damage. If nerve damage occurs with severe vision loss, then some of the treatment options that I will talk about today will also apply to glaucoma patients. So how do they present? What are the symptoms of an optic nerve dysfunction? In general, they will cause reduced visual acuity and an altered color vision, decreased color vision, impaired pupillary light reflex. At the bottom left, you see a patient's vision before the optic neuritis. And at the bottom right, in the right eye, you see the patient's vision after optic neuritis. Patients cannot see the colors as sharp as they were able to see before the optic neuritis episode. And there are many conditions that may cause optic neuropathy. So how we diagnose them, how we differentiate them. Although right now we have many technological devices, imaging techniques, still the most important part could be the anamnesis we obtain from the patients. And anamnesis is the history that we get from our patients. I was taught in my medical school that the anamnesis, the history, is half of the diagnosis. Although exceptions occur, usually the myelinating diseases, inflammatory conditions, ischemic conditions like vascular diseases, trauma cause rapid onset visual symptoms. On the other hand, glaucoma, toxic nutritional causes, infiltrative compressive disorders cause gradual vision loss. Hereditary diseases may cause rapid onset or gradual vision loss, depending on the genetic defect. Demyelinating diseases are a well-known cause of optic neuropathies, and the most common one is multiple sclerosis, MS. There are nearly 1 million people affected by MS in the United States. It's an autoimmune process where, for some unknown reason, the immune system attacks tissues of the body. MS is known since 19th century. Dr. Charcot, who was a French neurologist and known as the father of neurology, first described the condition. But one of the first cases of MS is believed to have been a Dutch woman named Litvina, who was born in the town of Schiedam in 14th century. Litvina fell while ice skating on the canals when she was 16 and developed symptoms of headaches, pain, trouble seeing, difficulty walking, and eventually paralysis of both legs, and that they were later associated with MS. Believing she became ill and suffered from the sins of the others, Church canonized her in 1890. Today, Litvina of Schiedam is the patron saint of ice skaters and an unofficial patron saint of MS patients. Other demyelinating diseases are relatively new and actually new entities in comparison to the MS disease. They entered to the neurology field with the discovery of some autoantibodies. An autoantibody is an antibody produced by the immune system that is directed against individuals' own proteins. An antibody was discovered in 2004, and MOG antibody was discovered only in 2007. In the beginning, they were considered as a type of MS, but now they are considered as different entities, and prognosis and treatment approaches change accordingly. Their visual symptoms will be similar to other optic neuropathies with reduced visual acuity, altered color vision, which may be more prominent in demyelinating conditions, and visual field defects. These are same features that we see in other optic neuropathies. Different than other optic neuropathies, these patients may also experience pain with eye movements and may complain of seeing flashing lights. Again, medical history is very important in diagnosis. We question about the visual symptoms as well as other neurologic symptoms like weakness, numbness in the body that may be associated with MS. Then we will do an eye exam and neurologic exam. In eye exam, 1/3 of the patients we will see swelling of the optic nerve head. When it affects the front part of the nerve, then we may see the swelling of the nerve. But in the majority of the patients, in 2/3 of the patients, it will affect behind part of the nerve. So in these patients, we will not see any abnormality when we do the eye exam in the beginning. We also perform blood work and MRI to exclude other causes of optic neuropathies, such as an infectious optic neuropathy, and also to confirm the diagnosis, we do the imaging with an MRI. Visual field test is a critical tool while evaluating for optic neuropathies. It's a clicking button test, and this is me taking the test here. In this test, the sensitivity of the vision is in different part of the visual field is tested. It uses a light spot that is repeatedly presented in different areas of the peripheral vision. In mild cases of optic neuropathies, patient's vision may be normal. But when we do the visual field test, we detect visual field cuts. Here we see a picture that illustrates central visual field defect. When we do the visual field test, we can catch these defects as shown here. In that visual field test, white part demonstrates the area that the patient was able to see, and the black part demonstrates the area that the patient was not able to see. This small area is a physiologic blind spot. Everybody has it. But on the central area that this patient missed these points, and it is consistent with a central visual field cut. Although MS is known for centuries, diagnosis of MS remains complicated. The first set of criteria were published in 2001 by a team led by Professor Ian McDonald, and it's called McDonald criteria. Basically, diagnosis is made with the previous symptoms, MRI findings, and spinal tap results. They have been extensively revised several times, and most recently in 2017. The revisions are made by a panel of MS experts who look at the most up-to-date research and how MS appears and progresses in patients. The last revision aims to expedite MS diagnosis, so patients may start medication earlier. And when we detect an optic neuritis related to MS or other demyelinating conditions, the first treatment option is giving high-dose steroids. However, in previous studies, it is shown that steroids do not change the final visual outcome in MS-related optic neuritis, but they expedite the vision recovery and also help with the associated pain. If you don't see enough response with high-dose steroids, then the next acute treatment option will be Plex, plasma exchange. In plasma exchange method, patients' blood removed and separated into plasma, the liquid part of the blood, and then the cells. Unhealthy plasma is substituted by healthy plasma, and then cells and healthy plasma are transfused back to the patient. This method is used for many autoimmune conditions, and main aim is to remove antibodies that cause the disease. For long-term treatment, there are therapies specifically approved for treating and managing MS, and more potential MS therapies in development today than another time in history. These are called disease-modifying drugs, and the goal is to reduce the relapses and preventing progression of the disease. I wrote down here just a few of them. There are many other medications that are being used for MS patients. These medications are managed by our neurology colleagues, and we have a great MS clinic at McGee Hospital. One of the medications that I noticed that many of our MS patients are treated with is Ocrevus, ocrelizumab, and it's only approved by FDA in 2017. For NMO, long-term treatment is different than the MS. Disease-modifying drugs for MS have shown to cause poor outcomes when used for NMO spectrum disease. Neuromyelitis optica is another kind of demyelinating condition. And therefore, the differentiation of MS and NMO is very important because you cannot use the same medication to treat these two different entities. Long-term treatment for NMO is usually done with previously known immunosuppressive medications such as rituximab, azathioprine, and mycophenolate mofetil. These immunosuppressive medications were widely used in other autoimmune conditions in the past, and there are recently approved new medications for NMO. These are some types of antibodies which neutralize the antibodies that cause the disease. In 2019, eculizumab or Soliris became the first FDA-approved treatment for NMO, neuromyelitis optica, in adult patients. In a study published in 2019, 98% of patients receiving the therapy were relapse-free around 3 years after starting treatment. This is actually a great success for the medication, but unfortunately, there is a major downside of these new medications. Similar to all new medications, they are very expensive. For example, eculizumab's cost for a year is around $700,000. The other optic neuropathy we frequently encounter in neuro-ophthalmology clinics is ischemic optic neuropathies. Ischemic means there is blood flow disruption to a tissue. There are two types of ischemic optic neuropathy. If it affects the front part of the nerve, this is the part we can see in our exam. It's here, the front part. Then we can see the disc edema in our exam, and it's called anterior ischemic optic neuropathy. If it affects the behind part of the nerve, it is called posterior ischemic optic neuropathy, and we don't see any abnormality in eye exam initially in these patients. Posterior ischemic optic neuropathies are much rarer than the anterior ischemic optic neuropathies, and they usually happen after a major surgery, which complicates with severe blood loss. The other classification for ischemic optic neuropathies is that arteritic and versus non-arteritic. Arteritic ischemic optic neuropathy, sorry for the medical abbreviations, they are very long here. Arthritic ischemic optic neuropathy is caused by inflammation of arteries supplying blood flow to the nerve. It is associated with systemic vascular inflammation. Non-arthritic ischemic optic neuropathy, which is called NIAN, is caused by reasons other than inflammation of the arteries, and the exact pathophysiology is not clear. They both present with sudden, painless vision loss. As I said, in arthritic ischemic optic neuropathy, arthritic refers to a systemic inflammation in these patients, and there is an inflammation in the arteries. And in particular, this inflammation is related to a condition called giant cell arteritis or temporal arteritis. This is a systemic inflammatory condition, not only affects the eyes, but also may affect heart and also brain. This is a potentially fatal disease and can damage the entire optic nerve head and may cause permanent massive vision loss if not diagnosed and treated quickly. 5 to 10% of anterior ischemic optic neuropathies are related to GCA. It is 3 times more common in women than men and exclusively affects people over the age of 50. For diagnosis of ischemic optic neuropathies, for arthritic ischemic optic neuropathy, medical history is important to reveal systemic inflammatory symptoms. Like these patients may have other symptoms like pain in the temples, pain when chewing, scalp pain, neck pain, muscle aches, fatigue, weight loss, fever. In eye exam, we will see optic disc edema in these patients. And we will check for inflammatory markers always for these patients. And the most sensitive diagnostic tool is getting a temporal artery biopsy, which may show the inflammation of the arteries. Treatment consists of high-dose steroids again. Initiation of steroid treatment as soon as possible is very important for these patients because if you have ischemic optic neuropathy related to GCA and do not receive any treatment, the other eye will be affected in the majority of patients within 1 week. This is a very short time. And the degree of vision loss in these patients is severe and permanent. Steroid treatment is widely used in medical practice and it is the mainstay therapy for this condition as well. But it's not perfect. It comes with many side effects like GI issues, osteoporosis, mood changes, elevated blood pressure and elevated blood sugar level. So due to the long-term side effects of steroids, there are other medications being used to replace steroids. And most common one is tocilizumab. And this is a relatively new medication being approved by FDA only in 2017. NIN is the non-arthritic form, is the most common acute optic neuropathy among individuals over the age of 50. It affects men and women equally. Insufficient vascular circulation in the optic nerve cause the disease, but the exact triggering factor remains unclear and controversial. Some suggest it is an arteriolar insufficiency, and some suggest it is a venous return problem. We don't know the exact pathology, but studies were able to point to risk factors for this condition. These are diabetes, high blood pressure, cholesterol, smoking, and sleep apnea. And these are risk factors that we can modify. And there is another risk factor that we cannot change. This is having small optic nerves. If you have small optic nerves, all the arteries, nerves, and neurons go through this small area, and then it increases for vascular insufficiency and therefore for ischemic optic neuropathy. Similar to anterior ischemic optic neuropathy, these patients present with sudden vision loss, usually noticed upon waking up from a night sleeps or even a nap. It is believed that the body's normal drop in the blood pressure during sleep, along with one or more underlying risk factors, triggers an interruption of the blood flow to the optic nerve. When we question these patients about their vision loss, they report a sudden onset vision loss, which helps us to differentiate it from other optic neuropathies. Also, they do not have any pain or systemic symptoms accompanying to the vision loss. On exam, we will see the swelling of the optic nerve head along with some bleeding, as we can see here. A visual field defect which affects just superior or inferior part of the field is typical for this condition, but it may present with any kind of visual field defect. Here we see a patient with ischemic optic neuropathy, and again, the black part shows the area that the patient was not able to see, and the white part the patient was able to see. And here we can see the typical visual field defect for ischemic optic neuropathy patients. For these patients, we always check blood tests for inflammatory markers to differentiate it from giant cell arthritis, because for giant cell arthritis, you need to start steroids as soon as possible. And sometimes when the presentation is not very typical for the ischemic optic neuropathy, we may get imaging to rule out other causes of optic neuropathy. And what is the treatment? Unfortunately, even though it is the most common cause of acute optic neuropathy in adult patients, in patients over the age of 50, we do not have effective treatment for this condition. Vision loss is usually permanent, and few patients show some slight modest improvement in their vision. Currently, our main goal is to prevent this condition from occurring in the other eye. The risk for second eye involvement is around 15 to 20% in the following 5 years. Since this is a vascular insufficiency, aspirin is widely used, but studies did not show any benefits of aspirin. But it is still recommended for patients who have vascular risk factors, such as diabetes or high blood pressure. Regulation of vascular risk factors is very important. Blood pressure, sugar level, and cholesterol level should be under control. Sleep apnea is another risk factor. If patients have risk factors for sleep apnea, we recommend having a sleep study and treatment accordingly. Multiple approaches to treat acute ischemic optic neuropathy have been investigated. These are some of the interventions investigated. I wrote down here: lowering intraocular pressure, neuroprotective treatment with brimonidine or L-DOPA, or decreasing edema with steroids or bevacizumab, but unfortunately neither proved a clear benefit. One famous historical study was ischemic optic neuropathy decompression trial. In this study, a surgical incision of the optic nerve sheath, which is the connective tissue surrounding the optic nerve, was performed to relieve the pressure around the optic nerve. It was a multi-center study with 25 clinical centers involvement in the United States. Began in 1992, and the study was terminated within 2 years because the surgery did not show any benefit, and perhaps it was harmful, so they terminated the study. In recent years, attention has turned to gene therapies, neuroprotective agents, and stem cell treatment. In an international multicenter study, they evaluated the efficacy of a gene therapy in non-arthritic ischemic optic neuropathy patients. They injected small interfering RNA called QPI into the eye to act as a neuroprotectant by inhibiting cell death. An interim analysis did not warrant to continue enrollment, and the study was terminated, unfortunately, and there was no result reported. In another study, they evaluated the efficacy of a botanical drug called RPH201, and which is an extract of gamma stick that induces neuronal differentiation and acts as a neuroprotectant. And they found that vision improved about twice as much in participants receiving this botanical drug than those receiving placebo. But this is a small sample size study with only 22 patients, and main aim of the study was to assess safety and tolerability of the drug. It was found to be safe, but to assess benefits, larger studies are required. One promising study seems to be stem cell treatment, and an important study about it is stem cell ophthalmology treatment study. This is a multi-center study with a large number of participants. There were 500 patients involved in this study. It is the largest ophthalmology stem cell study. This study evaluates the use of autologous bone marrow-derived stem cells for the treatment of retinal and optic nerve diseases. This is a list of conditions treated in this study: optic neuropathy, optic atrophy. Atrophy means reduction in size and as a result of irreversible nerve damage. And glaucoma were some of the optic nerve diseases in this treated in this study. And they did a sub-analysis of ischemic optic neuropathy patients in this study and published it in 2017. Results were really promising. There were 10 patients with bilateral sequential visual loss participated in the study with a history of non-arthritic ischemic optic neuropathy. Average age of the participants was 70 years and average duration of vision loss was 10 years. 80% of the patients experienced improvement and 20% remained stable. There was an average of 3.5 Snellen lines of vision improvement per eye. And Snellen is the chart we use to evaluate the visual acuity, and 3.5 Snellen lines improvement is really impressive. They suggested some possible mechanisms by which vision improved in this study. These are differentiation of stem cells into the neuron-like cells, production of some growth factors that promote regeneration of neuron cells, retinal ganglion cells, and also inducing new connections between the existing neurons. And there are ongoing studies for optic nerve regeneration, in particular actually at Fox Center in Pittsburgh. And Fox Center is the first national multidisciplinary research center for ocular regenerative medicine. And Dr. Sahel and Dr. Jeff Gross and their great team, they recruited a great team actually, working on optic nerve regeneration specifically. For those who are interested in that, there was a webinar about it, and I think we can share the link for this webinar. Hereditary optic neuropathies result from genetic defects that are passed down through the families. These are Leber hereditary optic neuropathy, autosomal dominant, and recessive optic atrophies. Leber hereditary optic neuropathy is a mitochondrial disease, which means it is only inherited through the mother because we get our mitochondrial genes from our mothers. Mitochondria is the organelle in the cell responsible for energy production. It is the most common inherited mitochondrial disease. It is seen as 1 in 50,000 people, so it is still a rare condition. And because it's rare, it affects less than 200,000 people in the United States. It's considered as an orphan disease. According to some estimates, there are around 10,000 Leber patients in the United States. And it's named after Dr. Theodor Leber, who studied the disease in 19th century. The patients with subacute vision loss of one eye, these patients have subacute vision loss of one eye, and then it affects the other eye in less than a year. Although patients are born with the disease, it usually manifests itself between the age of 10 to 30. However, the onset can occur at any age. Vision is usually less than 20/200, and they will also have color vision loss and visual field defects, the typical findings of all optic neuropathies. Diagnosis of Leber is not easy all the time, especially if the patient does not have a family history of the condition. Not every patient has a family history because many people with the mutation do not exhibit the disease. So mother can have the mutation but may not have visual field symptoms, and kids, especially male kids, may exhibit the disease. Or sometimes patients may have new mutations causing the disease, so they will not have any family history. Eye exam could be normal initially, but eventually patients will develop optic atrophy due to irreversible nerve damage. On the left, we see an optic nerve, which is pink and orange color. And on the right side, we see an optic nerve with optic atrophy. You can appreciate the white color of the optic nerve, which indicates an optic atrophy. And we performed MRI for these patients to exploit other causes of optic neuropathies, such as a tumor compressing the nerve. And genetic tests are very helpful for liver. There are mainly 3-point mutations account for more than 90% of the patients, and we can check for them with an easy blood test. Mutation 11778 is the most common one and reported to account for more than 70% of cases in Northern Europeans. In these patients, the main problem is that these mutations interrupt the normal energy production of the retinal ganglion cells. And without energy, cells will accumulate reactive oxygen species, and these are toxic and eventually will cause cell death. So the aim of the treatment will be to restore energy production or to decrease reactive oxygen species. There is a theoretical benefit from using antioxidants to help reduce the neurotoxic stress due to reactive oxygen species. Multiple supplements such as vitamin B12 and C, coenzyme Q, and lutein have shown minimal benefit, but may be recommended. Patients are cautioned to avoid neurotoxins such as alcohol or tobacco. These alcohol and tobacco may interfere with the energy production of the cell and may cause further cell death. One important treatment option is idebenone, which is a synthetic analog of coenzyme Q. A major limitation of coenzyme Q is its inability to cross the blood-brain barrier and mitochondrial barriers, so it will not be possible to reach to the mitochondrial genes. To address this issue, idebenone was developed and its use is investigated in RODOS study, Rescue of Hereditary Optic Disease Outpatient Study. The mechanism of action of idebenone includes stimulation of energy production and antioxidant effects. They randomized 85 patients with liver disease, and these patients either received idebenone or a placebo medication. The study failed to show any significant difference in visual improvement between the active drug and the placebo group. However, a trend was noticed in favor of idebenone, especially in patients with more recent disease onset. It was able, in these patients with a more recent disease onset, it was able to induce a meaningful improvement in the vision. So it was approved by European Medicine Agency to treat LABOR in 2015 for adult patients. But unfortunately, it is not available in the US, in the United States currently. But another study called PAROS study is ongoing to evaluate the long-term safety effectiveness profiles of idebenone. So it's possible in the future, according to these study results, it may be approved in the United States as well. Stem cell treatment was used in liver patients in the stem cell ophthalmology treatment study, but there were limited liver patients. They evaluated only 5 patients. They observed a significant improvement in the visual acuity, including counting fingers to 100, and one other patient showed improvement from hand motion vision to 2200. And they also noticed visual field improvements. So they concluded that stem cell treatment could be beneficial for liver patients, but of course, the study was very limited with a very small number of patients. So they recommended further exploration for these beneficial effects. In liver hereditary optic neuropathy, what is more promising, noticeable is gene therapies, because it makes sense when we think this is a genetic disorder. In gene therapies, the defective gene is replaced by the normal type gene so that the normal gene is expressed. For eye diseases in particular, it is an even appealing treatment option because retina can be accessed easily. There are 2 pivotal studies. These are rescue and reverse studies. In rescue study, there were 39 patients involved, and in reverse study, there were 37 patients. The main difference in these studies was the duration of the visual loss. In rescue study, participants had a visual loss duration less than 6 months. enabling a study of earlier treatment before most of the neuronal cells are damaged. And in reverse study, duration of visual loss was between 6 months and 1 year. One of the patients received therapy, one of the eye, just they treated only one eye in these trials, and the other eye was used for a control group. But something unexpected happened, and visual acuity improved similarly in both eyes. And then afterward, this is attributed to the transfer of the genetic vector to the other eye, and this was proved with animal studies. This is actually a good surprise, but it makes it difficult to interpret if the gene therapy was helpful or not, because in natural history of Leber, some patients may show spontaneous improvement in their vision. So researchers had to compare these studies results with the natural history of Leber disease, and they were still able to report significant improvement with gene therapy. Since there was improvement in visual acuity in both eyes unexpectedly, it made it difficult to assess efficacy of gene therapy. So they planned another clinical trial, and it was initiated in 2018. In this study, first affected eye received the gene therapy, and the second affected eye received gene therapy or placebo. So the goal was to compare difference in change from baseline visual acuity in the second affected eyes. It's not published yet, but preliminary results show that bilateral gene therapy show better visual acuity improvements compared to unilateral treatment, supporting the beneficial effects of gene therapy. Rescue and reverse were very important studies, but they are not the only ones that evaluated gene therapy for Leber. There are studies from China, Europe, also many studies from America. You can find these studies on clinicaltrials.gov. And also there will be a new multicenter genetic trial, and UPMC will be a part of the study. Details for now are not disclosed yet, and I'm not able to share them at this point, but I'm very excited about being part of this study and looking forward to this study. Lastly, I will talk about autosomal dominant optic atrophy. It is the most common hereditary optic neuropathy condition. Dominant inheritance means an abnormal gene from one parent can cause the disease. Its estimated prevalence is 1 in 12,000 to 1 in 50,000 people. It is also called Kier's optic neuropathy, who was a Danish ophthalmologist who studied 19 families with this condition. Individuals typically present with bilateral and slow vision loss, similar to other optic neuropathies, but this time the progression is very slow. And there is a gene detected for this condition. It's called OPA1 gene, but the genetic testing is not as easy as it is in the Leber patients, because there are many other mutations that may cause autosomal dominant optic atrophy, and it may be difficult to detect those mutations in one simple genetic test. Unfortunately, here there is no established treatment again, but the problem is again about the energy production. So we recommend patients taking coenzyme Q, idabanon, or vitamin supplements, and avoiding alcohol and tobacco is very important here as well. Stem cell also was studied in autosomal dominant optic atrophy, and they evaluated 6 patients, and 5 of 6 patients experienced a significant visual improvement, approximately 11 letters. This is my last slide. If we break down these patients, we can appreciate the improvement in the patients better. The patient 1, his vision was 20/80 in the right eye and 20/100 in the left eye, and it improved to 20/40 in both eyes after the stem cell treatment. This is a significant improvement. The second patient improved from 20/60 to 20/50 in the right eye, and from 20/80 to 20/40 in the left eye. And the third patient improved from 20/200 in both eyes to 20/150 in both eyes. And the patient 4, her vision improved from 20/200 in both eyes to 2100. So the vision doubled in this patient, which is actually very impressive. Patient 5 didn't show a significant improvement, and patient 6 vision also improved dramatically. Okay, thank you so much for your attention, and I will be happy to take any question. Thank you so much a lot for joining us today.
Well, thank you so much, Dr. Kocasarac. This is a pretty broad field now. As I look at this, and all the things that are happening are very exciting. So I imagine for you, it's an exciting time to be in this work. A few things that really stood out to me was, one, the very many different ways people can develop some vision loss because of their some sort of damage to their optic nerve, whether it be from blood flow related issues, or from ischemia, or from these inherited conditions, or from, as you said, glaucoma, which is the #1 cause of any of that optic nerve damage. But with all of those things, it seems like the solutions are multifaceted. There's all different types of things that could potentially help somebody, but it depends on the condition. It depends on the treatment for everybody. And I'm just excited to hear, one, that there are a lot of things being tried. I was excited to hear about some of the stem cell work. I was excited to hear about the gene therapy work for the inherited conditions, because again, we get to see that the work that's continuing to work to happen here at the University of Pittsburgh and with the Fox Center for Vision Restoration, to try to tackle some of those same problems in the same way. And again, aiming and driving towards some answers for some of our patients. So we got a lot of questions already. So this is time to get to the viewers' questions, and I'll get to those. And certainly I'll remind everybody that you can submit those now. I did right away. Someone wanted to know if you were going to be talking about the LHON, the Leber's inherited. Of course, you covered it very, very well. And if there are any more questions, please let us know. So how closely do the rheumatologists, and I think this is a good question, and neurology departments work with ophthalmology and patients that exhibit these issues, especially as we talk about things like MS? Is it common for you to work with those other specialties?
Yeah, we have a great collaboration with our neurology colleagues, and we have a great MS clinic, MS center at Maggie Hospital. They're very experienced, and they see MS and other demyelinating conditions all the time. So they have a huge amount of patients and very experienced. And we collaborate them very often. And we have actually neuroimmunology meetings weekly. We discuss some of the complicated cases with them. And the medications for MS and NMO, they have more experience than us in managing these medications. So the medications, and there are many fine new medications, as I discussed in one of my slides, and there are others coming, and even neurologists cannot catch up with these medications. Right now, there are many medications, and it is good to have this experience while managing these patients with different types of medications. It's very important to know how they will affect the vision, what are the side effects of this medication. You need to be very experienced while implementing these medications on your patients. So I feel very happy and privileged to be able to work with them.
Well, we have very strong people in neurology here, as well as in rheumatology. So I imagine that for you too, it's a good collaborative environment. Definitely.
And some of the optic neuropathies are related to systemic conditions. Some of them are related to neurologic conditions, and others, just you mentioned, some of them are related to rheumatologic conditions, such as systemic lupus erythematosus is a relatively common rheumatologic disease, and it may cause optic neuropathies. So for these patients, we collaborate with our rheumatology colleagues.
Wonderful. So what optic neuropathies would cause someone to have double vision? one of these, or
Optic,
could it be many of them?
optic neuropathies shouldn't cause double vision.
Okay, okay. So wouldn't
There are-
necessarily, that would be one of the things that you're not looking for, be some other
Yeah.
diagnosis.
There are two main systems of the eyes. One of them is efferent, which is bringing the information from eye to our brain. And one of them is efferent with E, which brings the information from our brain to eyes. So optic nerve is the system that brings information from eyes to our brain. But the double vision occurs when there's a problem, interruption of connection between the brain and the eye, when there's interruption of the efferent nerves
Okay.
that controls the eye movements. Optic nerve is not involved in eye movements.
Okay, well, that's good for the person who asked that question to know. If someone has like palsy or weakness in one of the cranial nerves affecting their vision, you know, and I guess it'd be for any kind of, for when there's nerve damage like that, that potentially could be resolvable, you know, and I know sometimes that happens. Is there a time frame that you look at that can happen?
Yeah, for cranial neuropathies, the most common reason is microvascular diseases like hypertension, diabetes, cholesterol. If it is related to these conditions, we expect to see improvement within 3 to 6 months. We expect to see improvement up to 1 year, but the main improvement, the significant improvement occurs in the first 3 to 6 months.
Okay.
And there are other causes of optic cranial neuropathies. So it depends on the underlying condition as well.
Okay. Well, I again, some of these questions I can, you know, I think we can still go with, even though they're a little bit specific, but I think some of them are interesting here. So the question is about optic nerve damage due to surgery, you know, or I guess you could relate that to any kind of sudden ischemic, like where there's blood flow loss and there's nerve damage or even some partial nerve death. The question here is there any studies or treatments? And, you know, I think I, of course, know the answer, but hopefully we can provide some hope related to that as well.
If there is, actually, eventually it all comes to how we regenerate a nerve. Nerve may die because of many different factors, but what they are trying to do, I'm more involved in the diagnostic part. I have just started working here, actually. I want to be involved in the research part more in the future, because there's a great research center here, Fox Center, and what they're working on is regenerating the nerve. And it will be a solution for many of the optic nerve neuropathies, because the problem here is, whatever the reason is, eventually the cells die and we are not able to regenerate the nerves. If you will be able to regenerate the nerve, then we will be able to help maybe all of these patients.
Thank you. So now this again, I think we're, you know, looking at some problems that are going to be difficult to solve, but is there any stem cell or gene therapy available now for things like NAION, and that's NAION, and
yeah.
explain the
Yeah, I also struggle to say that.
Thank you.
So yeah, there are studies going on, but there are only studies right now. There is no available treatment for that. They are still evaluating the long-term
clinical trials right now.
Clinical trials. They are evaluating for the safety and effectiveness in the long term. There are, I think, two, 3 centers doing that, and also we are doing some stem cell treatment, but I am not sure which stage at this studies.
Right. Yeah, and you know, of course, we're now seeing more clinical trials, and you mentioned a few. That's encouraging, because there were not too long ago far less than what you presented today, and I think that's encouraging for those who are looking for those answers. And again, I think we share with you, not only just here in Pittsburgh, but throughout the world, there are many that are working on trying to develop new therapies to come up with more clinical trials. And based on what we heard today, I think we'll see those stem cell related, gene therapy related. I think we'll see, some things with tissue engineering like we're doing here in Pittsburgh, and some of these other types of innovative ways to try to bring back vision to those people that have lost it. But I think just it's good to stay connected like you are here with these webinars. Stay connected by looking at our website. We send information out. We certainly would let people know as things are developing. And you also can always, just talk to your doctor. They're the ones who are going to be able to tell you about any of those upcoming clinical trials. So you're doing the right thing, folks, by staying connected. When will better stem cell therapies available for glaucoma, or even glaucoma that's controlling, to essentially stop the visual field loss from glaucoma? Are there some regenerative therapies, I guess we would say, related to that you're seeing?
For glaucoma patients, and this is the most common cause of optic nerve problems, optic neuropathies, the main aim is to prevent nerve damage. And the risk factor that we can change is lowering the intraocular pressure for these patients. And there are many medications and surgical options for these patients. But unfortunately, glaucoma is a disease that don't show much symptoms. Some patients may present late, and for some patients, even though we lower the pressure, we do all the medication surgeries, the nerve damage unfortunately can occur. And when the nerve damage is there, the treatment is again the same. We need to regenerate these nerves. And that's what many studies are about now, regenerating these nerves, and mainly with stem cells. And the results are really promising. Actually, I'm very excited to be a neuro-ophthalmologist right now, because these diseases are around for many, many, many years, but we were not able to treat, or there weren't even, as you said, there were not that kind of studies back then. But right now, there are many studies going on. Hopefully, in the near future, we will have some treatment options for these patients with nerve damage. But unfortunately, science may take some time, but I'm very hopeful about it and very excited about it in the near future. Rather than saying, unfortunately, we don't have anything right now, we may offer some treatment options for these patients with nerve damage.
Yeah, and I will encourage everybody, again, as you mentioned before, we did a webinar on what the Fox Center is doing, that's available on our website at www.ionia.org. But we're also going to repeat a webinar, bring back the scientists that are doing work, and they've progressed some of the work. I can share that with you to different stages, and it's still not in clinical trial, and still no planned clinical trials. But I will let you know we're going to do another webinar, so please look for that and tune in June. You'll see an invitation for that coming up here. But it is a promising time, and we do hope that you'll see more, and that you, doctor, will have more options in your clinic. Now, the last question here is actually about myasthenia gravis. Maybe this was, how is myasthenia gravis related to optic nerve? I don't know if this is a mistake related to multiple sclerosis. They're different, of course, but is myasthenia gravis related? Does that have any relationship to optic nerve regeneration or optic nerve damage?
Yeah, myasthenia gravis is not related to optic nerve. It's about the eyelids and how the eyes move.
Okay.
And myasthenia gravis does not affect your vision.
Okay. Well, I guess good to know. And that is the last question. And guess what? It is 12:59. So we're ending right as we always promise we will, right by 1 o'clock. So thank you so very much. Again, it's been nice to get to know you better through this process and all the things you're doing. And it's really fantastic. So I hope that we get to hear more from you and hopefully have some more answers for people in your clinic. So thank you so very much. And we look forward to, again, seeing our audience. You'll get invitations to our next program. It'll be in 2 weeks. And thank you for your time today.